Welcome to Cardiovisual. My name is Paul Tucker. I'm a cardiologist in Austin, Texas. We see routine cardiac patients. We're a primary, secondary, and a tertiary referral center. So we see patients who come in right off the street who've never had a heart problem before, but we also get patients transferred in from other hospitals. Our hospital is a 350-bed acute care hospital. We do over 650 coronary interventions per year, and approximately 30% of our patients have risk factors for acute kidney injury. Today I want to talk to you about reducing acute kidney injury in the cath lab. This is a very big problem in today's day and age. We have a lot of patients who come to the cath lab with pre-existing kidney problems, renal insufficiency. Some patients come in urgently or emergently with heart attacks, and we have no idea if their creatinine is normal or not, and yet those patients are at very high risk for developing acute kidney injury following the intervention. So there are a lot of patients who are at risk for it, and one of our goals is to figure out how can we reduce the risk of them having problems from the contrast that we use. It's been shown over and over again in studies for many years that the number one risk factor for contrast-induced nephropathy is giving too much contrast. And so anything we can do to reduce that amount of contrast given is a great idea. We consider patients at risk for AKI if they are of advanced age, if they have congestive heart failure, diabetes, coming in with acute coronary syndrome, or coming in with a heart attack. There are real morbidity and mortality implications when someone develops acute kidney injury after an intervention as compared to not getting it. For instance, there's a 20-fold increase in the risk of having a heart attack or death following the development of acute kidney injury after an intervention. There's also an increased risk of bleeding. There's always going to be an increased hospital stay associated with this. And the average cost of an acute kidney injury episode is at least $10,000 per episode, if not more. At our hospital, we had a real problem with acute kidney injury, as high as 12% going back a couple of years ago. We defined acute kidney injury as an increase in the serum creatinine of 0.3 milligrams per deciliter within 48 hours of the procedure, or a greater than 50% increase in the creatinine level in less than 48 hours. So it's either 0.3 higher or a 50% increase. So what we did is we started making sure that we were screening patients for this. We started hydrating them better. And then at some point during the process, specifically the fourth quarter of 2018, we started using a device called Divert, which is a contrast diversion mechanism to allow you to save contrast. And also it allows you to quantify exactly how much contrast you're using. So when we started this study, our initial acute kidney injury for all comers was 12.5%. We started aggressively screening patients, making sure they were getting hydrated, and we were able to bring those numbers down a little bit to about 9%, but it was only after we started using the Divert system, which is a contrast saving device, that we actually reduced our acute kidney injury rate to as low as 2%, which is where we're at now. Over the time period of quarter 1 2018 to quarter 3 2019, we had an absolute AKI reduction of 10%, which was a relative reduction of 83%. So a really huge drop. We also learned that on average we were saving 42 milliliters of contrast per case. If you also look at the device itself, it tells you how much contrast as a percentage that you saved or diverted, and it's really very helpful. While you're doing the case, you actually see in real time how much contrast you're using, how much is being diverted, and how much you're saving compared to what you would have done if you had not used the device. So a 42% reduction in contrast volume is amazing, especially when you don't sacrifice any quality of the images and you don't really sacrifice the number of images. In general, in our cath lab, we try to use less contrast than 3 times the patient's glomerular filtration rate, or GFR. If the patient's GFR, for example, is 50, we set our maximum at 150 milliliters, and that goes into the console that we're watching while we do the procedure. It's pretty amazing that you can literally see milliliter by milliliter how close you're getting to that. And just like a gas gauge on your car, starting at green, then yellow, then red, you can see when you're getting close to reaching that contrast limit. One of the other things that we studied were the economic outcomes. And we discovered that the number of patients needed to treat with the divert device was only 10 if you wanted to save one patient from acute kidney injury. As many of you may know, frequently with any sort of drug or intervention, you have to treat anywhere from 50 to 100 or even 200 patients for just one person to see the major benefit that you're looking for. But with divert, we have found that you only had to treat 10 patients to save one patient from acute kidney injury. So if the device costs roughly $350 per case and you use it for 10 cases at a cost of $3,500, but you save that one patient out of 10 from acute kidney injury at a cost of $10,000, your net savings is already at $6,500 after just using it for 10 cases. This is why it's become very popular in our Cath Lab. At our hospital, another high-risk group of people that comes in are the patients with STEMI, or ST elevation MI. These are patients having a heart attack. We have no idea what their creatinine level is from the field. They usually come from the ambulance directly to the Cath Lab, frequently bypassing the emergency room altogether. So we don't have any lab on them when we're starting. And yet these are patients who have a very high risk in all of the studies of having acute kidney injury. Sometimes it's because they're in shock. Sometimes they have low blood pressure. Sometimes it's simply low cardiac output related to their heart attack state. Many of them have diabetes. Many of them have pre-existing kidney disease. And you don't know a lot of that when you start the case. So we have made it routine at our hospital that every MI patient who's coming into the Cath Lab gets the divert device. It only takes 2 or 3 minutes for us to set it up. It's usually happening simultaneously while we're getting the patient prepped and draped for the procedure. We have found that it does not add at all to our door to balloon time, and it gives us the satisfaction and the comfort of knowing that we're using a lot less contrast than we would have otherwise in a patient in whom we have no idea what their baseline kidney function is. We're not only saving kidneys, preventing all of the other complications that occur with acute kidney injury, but we're also saving length of stay and real dollars.